Since the discovery of CPR in the 1950s, much has been learned about resuscitation physiology. The increased knowledge about how blood moves and the effect of ventilation has resulted in some dramatic improvements in resuscitation. For decades, there was very little appreciation of how ventilation impacted the overall effectiveness of CPR. Overventilation causes a decrease in cardiac preload and decreases blood flow during CPR. In head-injured patients, overventilation causes respiratory alkalosis and increases intracranial pressure. One paper by Ofterheide et al., published in Circulation in 2004, helped bring the problem of hyperventilation in failed resuscitations into focus. Rescuers were studied to determine their actual ventilation rates in field practice. The observations were startling. Patients were routinely being ventilated at rates over 30 times a minute. Even after retraining, these experienced rescuers only slowed their ventilation rates to 20 times per minute. In the animal lab, only 1 of 7 pigs that were hyperventilated survived. Of the pigs that had controlled ventilation, 6 of 7 survived. It became clear that increased emphasis needed to be placed on slower and more controlled ventilations to improve resuscitation outcomes. Since 2005, AHA guidelines call for ventilation volumes to be limited to 6 to 7 milliliters per kilogram, and that ventilations be given over 1 second to decrease airway pressure, and the rate be reduced to only 10 times per minute. Given that EMS providers are highly trained and skilled, the question must be asked, why do medics lose control of ventilations during resuscitation? Even the best organized resuscitation efforts can create a sensory overload and cause rescuers to become distracted. In many cases, rescuers are so overtasked that a bystander or a minimally trained rescuer is assigned the critical task of ventilation. Plus, advanced airways of all types allow for easy runaway ventilation. In overcoming quality issues, there is no substitute for training and having technology to help overcome clinical issues. One training tool to help rescuers understand how to ventilate is the O2 Mini Ventilation Training Analyzer. It provides immediate visual feedback when rescuers are squeezing a bag so forcefully and quickly that gastric insufflation will occur. Another device is the Smart Bag manufactured by O2 Medical Technologies. It's an inexpensive device that helps control ventilations and keep airway pressures low. The Smart Bag is equipped with a flow restrictor that prevents a rescuer from squeezing the resuscitation bag too forcefully. If the bag is being squeezed correctly, the bag is easy to squeeze. If the rescuer attempts to squeeze the bag too hard, the flow restrictor engages and reduces the flow to less than 40 liters per minute. It's also equipped with a timing light to prompt rescuers on the correct rate. Another device from O2 Medical Technologies is the CareVent Automatic Transport Ventilator. It's a simple handheld device that allows rescuers to rapidly set rate and volume. It consistently delivers the proper inspiratory-expiratory ratio and essentially delivers perfect ventilations in terms of rate, volume, and force. Combined with a simple disposable circuit, it provides hands-free, perfect ventilation when an advanced airway is being used. Resuscitation success depends on controlling both circulation and ventilation. While ventilation was once presumed to be simple and uncomplicated, research has helped us understand that more isn't necessarily better, and that ventilations must be controlled. To achieve optimal ventilation and oxygenation requires training and technology such as the Smart Bag, the CareVent ATV, and the Ventilation Training Analyzer.